Part 2, 1 MechanismOF IBS, 2 Diagnosis of IBS, 3 Differential Diagnosis of IBS, 4 Investigations of IBS, 9 Mechanism. 1 Genetic, environmental, and psychological factors seem to be important in the development of IBS. Studies have shown that IBS has a genetic component even though there is a predominant influence of environmental factors. 2. There is evidence that abnormalities occur in the gut flora of individuals who have IBS, such as 1. Reduced diversity. 2. A decrease in bacteria belonging to the phylum Bacteroidetes. 3. And an increase in those belonging to the phylum Firmicutes. The changes in gut flora are most profound in individuals who have diarrhea predominant IBS. 4. Antibodies against common components, namely flagellin, of the commensal gut flora are a common occurrence in IBS-affected individuals. 5. Chronic low-grade inflammation commonly occurs in IBS-affected individuals with abnormalities found including 1. Increased enterochromaffin cells, 2. Intraepithelial lymphocytes, 3. Mast cells resulting in chronic immune-mediated inflammation of the gut mucosa. IBS has been reported in greater quantities in multigenerational families with IBS than in the regular population. It is believed that psychological stress can induce increased inflammation and thereby cause IBS to develop in predisposed individuals. 10. Diagnosis. No specific laboratory or imaging tests can diagnose irritable bowel syndrome. Diagnosis should be based on 1. Symptoms, 2. The exclusion of worrisome features, 3. And the performance of specific investigations to rule out organic diseases that may present similar symptoms. The recommendations for physicians are to minimize the use of medical investigations. Rome criteria are usually used. They allow the diagnosis to be based only on symptoms, but no criteria based solely on symptoms is sufficiently accurate to diagnose IBS. Worrisome features include 1. Onset at greater than 50 years of age, 2. Weight loss, 3. Blood in the stool, 4. Iron deficiency anemia, 5. Or a family history of colon cancer, celiac disease, or inflammatory bowel disease. The criteria for selecting tests and investigations also depends on the level of available medical resources. Rome criteria. The Rome 4 criteria includes 1. Recurrent abdominal pain, 2. On average, 3. At least 1 day/week in the last 3 months, 4. Associated with 2 or more of the following criteria: A. Related to defecation, B. Associated with a change in frequency of stool, C. Associated with a change in form, appearance, of stool. Physicians may choose to use one of these guidelines or may simply choose to rely on their own anecdotal experience with past patients. The algorithm may include additional tests to guard against misdiagnosis of other diseases as IBS. Such red flag symptoms may include 1. Weight loss, 2. Gastrointestinal bleeding, 3. Anemia, 4. Nocturnal symptoms. However, red flag conditions may not always contribute to accuracy in diagnosis. For instance, as many as 31% of people with IBS have blood in their stool, many possibly from hemorrhoidal bleeding. The diagnostic algorithm identifies a name that can be applied to the person's condition based on the combination of symptoms of diarrhea, abdominal pain, and constipation. For example, the statement 50% of returning travelers had developed functional diarrhea while 25% had developed IBS would mean half the travelers had diarrhea while a quarter had diarrhea with abdominal pain. Differential diagnosis. 1. Colon cancer. 1. Inflammatory bowel disease. 2. Thyroid disorders, hyperthyroidism or hypothyroidism, 3. Giardiasis can all feature abnormal defecation and abdominal pain. Less common causes of the symptom profile are 4. Carcinoid syndrome, 5. Microscopic colitis, 6. Bacterial overgrowth, 7. Eosinophilic gastroenteritis, 8. Celiac disease, 9. Bile acid malabsorption, 10. Colon cancer, 11. Dyssynergic defecation, 1. Parasitic infections, 2. Lactose intolerance, 3. Small intestinal bacterial overgrowth, 4. And celiac disease. An upper endoscopy with small bowel biopsies is necessary to identify the presence of celiac disease. An ileocolonoscopy with biopsies is useful to exclude Crohn's disease. 16. Some people, managed for years for IBS, may have non-celiac gluten sensitivity, NCGS. Gastrointestinal symptoms of IBS are clinically indistinguishable from those of NCGS, but the presence of any of the following non-intestinal manifestations suggest a possible NCGS: 1. Headache or migraine, foggy mind, chronic fatigue, fibromyalgia, joint and muscle pain, leg or arm numbness, tingling of the extremities, dermatitis, eczema or skin rash, atopic disorders, allergy to one or more inhalants, foods, or metals, such as mites, Graminaceae, Parieteria, cat or dog hair, shellfish, or nickel, depression, anxiety, anemia, iron deficiency anemia, folate deficiency, asthma rhinitis, eating disorders, neuropsychiatric disorders, such as schizophrenia, autism, peripheral neuropathy, ataxia, attention deficit hyperactivity disorder, or autoimmune diseases. An improvement with a gluten-free diet of immune-mediated symptoms, including autoimmune diseases, once having reasonably ruled out celiac disease and wheat allergy, is another way to realize a differential diagnosis. Investigations. Investigations are performed to exclude other conditions, 1. Stool microscopy and culture, to exclude infectious conditions. 2. Blood tests, full blood examination, liver function tests, erythrocyte sedimentation rate, 3. And serological testing for celiac disease. 4. Abdominal ultrasound, to exclude gallstones and other biliary tract diseases. 5. Endoscopy and biopsies, to exclude peptic ulcer disease, celiac disease, inflammatory bowel disease, and malignancies. 6. Hydrogen breath testing, to exclude fructose and lactose malabsorption. Comorbidities.